Good afternoon, everyone. Thank you so much for being here for today's webinar organized by the STEP section of the AFPBN, the French Association of Biological Psychiatry. I am very happy to welcome today two superstars working on accelerated TMS since years and dealing with pioneering work, and we have a great opportunity to have with us today Professor Nolan Williams. Nolan Williams is a professor of psychiatry at Stanford University in the Department of Psychiatry and Behavioral Science. Nolan is a double board certified neurologist and psychiatrist, and he is the inventor of the accelerated theta burst protocol called SAINT protocol, and we will be discussing about this very innovative new treatment for patients suffering from depression. It's also a special day for me to welcome Nolan, since I was lucky enough to spend 2 years in Nolan's lab. Nolan is the director of the Brain Stimulation Lab at Stanford, and the Brain Stimulation Lab runs a lot of clinical trials working on, and developing the same protocol, but also digging into some neuroimaging aspects and biological response to the stimulation, as well as other rapid effect antidepressants and also psychedelics such as ibogaine. So thank you so much, Nolan, for being there. And also it's my immense pleasure to welcome today Chris Bacon. Chris Bacon is a professor of psychiatry at Ghent University. And Chris pioneered work on the mechanism of action of accelerated and TMS protocols, and he is the current elected president of the European Society for Brain Stimulation, who helped us to set up and organize this webinar. So, Chris, thank you so much for being here. I was lucky enough as well to work with you since 2 years, since I am back from Stanford, and this is an immense pleasure to have you both guys talking about accelerated TMS over the next 2 hours. This webinar will be, so first, a little ad. So we, as I told you, this webinar is organized on behalf of the French Association of Biological Psychiatry and Neuropsychopharmacology and the European Society for Brain Stimulation. So please become a member of the AFPBN. The AFPBN is an association and gathering scientific community interested in a lot of different fields in the biological psychiatry, from neuropsychopharmacology to neuromodulation techniques and neuropsychology and a lot of other important domains in our field. So this is the occasion to become a member of the AFPBN community, and we have a big TMS community represented by the STEP section. The STEP section is one of the first sections that has been created in the AFPBN, and is very active and offering a lot of sessions, training sessions and certifications over France. And I would like to thank the full STEP section, because I am probably the youngest in the section, but I would like to thank Anne Sauvaget, David Sekeli, Emmanuel Poulet, and Jérôme Brunelin, who helped me to set this meeting up. So I think that we should be ready to start. Sorry about sorry about when you need to work as a tell us verbally. Okay. So okay. So I think we are ready, and I will give the mic to Nolan to present his talk about accelerated TMS. So thank you so much for being here. And the second part of this presentation will be run by Chris, who will start discussing with Nolan about a few aspects about the same protocol and accelerated TMS, and then we will have an open discussion for you guys too. So feel free to press the questions button and bring any question you may have at the end of the presentation. Thank you again, Nolan, for being here, and you can, slide your yes, and let's switch seats.
Good. Thanks for having me, Jean-Marie. It's an honor to be here, to do this here in Paris, and to spend time with you all and with my old friend Chris as well as Jean-Marie. It's great to spend some time with you guys. So yeah, really honored to be here. All right, so I'll talk about SAINT and accelerated TMS protocols. I'm Nolan Williams, and at Stanford. All right. So disclosures, so I'll talk about TMS generally, talk about data burst more specifically, and then talk about what we've been working on, and and some spinoffs from that. So I don't think I have to tell this esteemed group what the problem is, right? The problem, everybody knows the problem is that depression's a big problem. It's very disabling. It's, in 2017 was the most disabling condition worldwide. I think it's probably still true. And whatever you think about oral antidepressants, they don't work very fast, right? So at kind of the base case is, how well they work, is arguable, but the speed in which they work is not, it's quite slow, and it doesn't really meet the acuity of the illness, right, in some circumstances. And as we all know, people cycle through various oral antidepressant trials when they cross that threshold of becoming treatment-resistant depression over and over again over the course of sometimes years of their lives, and so it becomes, a chronic illness in that circumstance, and oral antidepressants don't really affect suicidal ideation. And so we, in my lab, I think, others on this call, really only see people in that bottom green box, right? That box of, failed a number of medications. They've been ruled out for medical causes for depression, and then they come see us when they're when they're in this kind of state of what's next. And what's really interesting about this, there's a paper published in the American Journal of Psychiatry recently. Martijn Arns, who I think a lot of you all know, was a co-author on it, where they showed that in that second med failure, make a selection of a med or RTMS, they were able to see 5-6 times the effect and remissions with RTMS compared to meds. And so we're really entering into this phase now where neurostimulation is kind of the clear, hopefully soon the standard of care once you get into that green box, and we may even be able to move it up further, right? And I'm talking about just even conventional run-of-the-mill standard 6-week TMS. And so I also don't, again, need to tell this group how disabling this problem is, but I really like this graph, and you always have the medical student in the grand rounds that has their jaw dropped when they see this, right? Which is, this is an incredibly disabling condition, and why I think, we everybody thinks that we should figure out how to treat this. I think what I hear sometimes, it's always kind of a complicated conversation, is around how much money we should spend to fix it, right? And there's a certain amount of, well, do you really need the MRI? Does it really need to be, I'll talk about all the same protocol later, but do you need all these things in order to do it? Can't you just pat them on the back and send them out, or whatever delusional thing people have, right? And obviously none of you guys have that, but more lay populations or other medical specialties where it's like, whereas, what I would say to you with this slide is, I would argue we should be spending as much, if not more money on depression patients than we spend on patients acutely having a heart attack, or patients dying of an incurable cancer, which, at least in the United States, we spend an enormous amount of money on those two problems. And so the idea that we'd spend some money on severely depressed patients. And then, relatedly, I think it's important to understand that there's and I think this part may be a little bit more unique, and I'd love to hear some feedback from you all on this. But in the United States, especially, and we were talking about this a little bit earlier, it's just kind of a different healthcare situation. And so this, in my discussions with Jean-Marie, this is a particularly striking set of statistics, but people can only spend about 7.5 days on average on the inpatient unit. And so in the United States, this becomes a huge problem because, unless the person's actively voicing active suicidal ideation with a plan and intent, then they get discharged out of the hospital. And when you're in that boat, it's very stressful as a physician to kind of deal with that, because you don't have the luxury of keeping people longer. I understand that there may not be as much pressure in France, although maybe that's changed over the years, to do that. But I think either way you look at it, whether it be there are these extended courses in countries like this, or in the rest of Europe or in Japan or whatever it is, which is a lot of costs under the system, or we don't have much time, it doesn't fundamentally matter. I think the reality is that we need to have treatment approaches that match the level of acuity and severity of the problem, that can take care of the problem within the hospitalization. Because that's what we have in other areas of medicine, right? Where somebody's having acute stroke, we can bring them in, we can give them TPA, we can pull a clot out, whatever it is, and they're walking out with the intervention done and whatever outcome has happened, right? Or if I'm having an acute heart attack, you can go in, or an arrhythmia, you put the pacemaker in, whatever it is. You can see all these areas of medicine where, as you increase the acuity of the illness, you increase the number of tests and treatments that happen in that setting, right? And really, really trying to, use that example to transform how we think about, idiopathic psychiatric illness. It's particularly humbling for me to be here in Salpêtrière, because that's what happened in many cases here, right? That we took things that we thought, that you all took things that, in the days of Charcot, where people thought that this was, a psychiatric illness, and you were able to then figure out, no, in fact, whatever it is, Parkinson's, Tourette, whatever it was, or neurological illnesses. And so that idea of being able to apply that kind of frame of ultimately circuit-based thinking to the problem. And so in the U.S., people sit in hallway beds waiting on psychiatric facilities. I can imagine maybe some of that happens here, and I would argue that what TMS is really is what the transcutaneous pacemaker was, as it relates to pacing the heart back in the 40s, right? That in many ways it's an important tool as a treatment, it's an important tool as a scientific probe, but I would argue it's an important tool as a prototype for developing other therapeutics, right? In the same way that the externalized transcutaneous pacemaker was an important tool for understanding how to actually build the implanted pacemaker, right? And that one actually really influences the understanding of the other. And so the other thing, and I think I don't have to tell this group any of this either, but I'll just repeat it because it's in my slide deck. The the TMS technology, that we use, sorry, and I'm trying to deal with two audiences. The stimulation approaches that we use are really what the treatment is, and the device is kind of like a scalpel, right? And so you can do a surgery that's highly effective. You can do a surgery that's not quite as effective, but it's pretty effective. You can do a surgery that is not at all effective, or you can do a surgery that is bad with the same scalpel, right? And so the scalpel doesn't change. It's the protocol or the technique that you're using with the scalpel. And I'd argue that the TMS device is the physical device that provides the protocol, but the protocol is the treatment. And I think that's a really important point. And I think you all obviously get this, but this idea that's why you can have changes in efficacy or changes in speed or whatever it is, because in fact, it all has in some ways to do with the treatment itself being the protocol. And that treatment emerging from the early days is this idea of a stimulation approach that drives the brain in a direction, as evidenced by some surrogate like changes in motor potential, coupled with some, increasingly more precise target of where you should do that in, right? And so, this is the video.
Yes, first video, yeah.
Oops. Okay, it worked. All right, so, conventional TMS, and this is all kind of oversimplified, but just to give people an idea, for those of you that don't do this all, every day, which many of you probably do, uses scalp-based heuristics to determine general position of the coil, most of the time within the left dorsolateral prefrontal cortex using trigonometry. The issue ends up being that if you're trying to hit a specific brain target, you can't consistently hit the same brain target if you're trying to consistently hit the same skull target. Those two things aren't possible because, as you all know, a given brain network node and a given skull position are rarely found in the same two people, right? And so it's impossible to create a skull target position that's going to recapitulate a brain network position, at scale, right? And so you could say, well, why do they do that? There are a lot of very important reasons why that was done. Essentially because at the time, it wasn't known where to hit, and we didn't have the technology to figure out where to hit. So in some ways, we had to do it in the skull way to give us enough evidence to be able to figure out how to do it in a different way. And so this is the original TMS protocol. And as you can see, there's a 6-week course. It really, mimics many of the oral antidepressant sorts of timing in the sense that, you're really not looking at a rapid approach. And it takes quite a bit of time during the day. And so people would have to, sometimes take multiple hours off in a day from work, right? And that's really, I think, where people ask me all the time, well, why isn't TMS more ubiquitous within at least U.S. culture? And I would assume this is true in France and Europe too, is this idea that at the end of the day, you have to go and talk to your boss and tell them, hey, I'm depressed and I'm not going to be in work part of the day because I've got to go do TMS, between the driving and the 40-minute treatment and all that. It's like an hour and a half or 2 hours to get back and forth from work or whatever, right? And so that's not something that's that quick or easy to do. But nonetheless, about a third of people, as you all know, remit, another third are responders, non-remitters, and another third or more non-responsive. More recently, Canadian friends did a non-inferiority trial against conventional TMS, where they were able to show that 3 minutes of ITBS was as effective as conventional RTMS, and that 3 minutes of ITBS is much more efficient because it mimics mammalian neurobiology, mimics the hippocampal discharges that happen, to signal memory signals within mammalian brains. So we are able to exogenously apply that information into the human brain and change the cortical excitability. And that looks like a pattern within a pattern. So 50 hertz bursts every fifth of a second in the case of excitation for 2 seconds with an 8-second interval. In the case of inhibition or depotentiating stimulation, there's no intertrain interval, and in excitation you get an increase in the motor evoked potential. And people have played with this idea of being able to give more stimulation pulses in a given session. And this was that non-inferiority trial, quite non-inferior, similar to the trial I think that was shown earlier with the 4D trial. And so this is what led to the FDA clearance. Here's the second FDA clearance that involved a single 3-minute ITBS session per day, 5 days a week for 6 weeks. So this showed non-inferiority. And so we got interested in this idea of can you apply this in a spaced paradigm that would allow for more rapid effects? And not just more rapid effects, but the ability to use principles of learning that we've figured out how to more optimally apply since the original RTMS approaches. And so, the first question is, if you're going to re-engineer TMS, is the how, right? How, and you have to kind of go back to first principles. And first principles are, at what intensity do I give ITBS for the number of pulses, right? And so is there an interaction between the pulse dose and the intensity in which the pulses are applied? And what you see from this, from Charlotte Nettenkoven's work, is this idea that there is a sweet spot of 90% in motor cortex of the motor threshold, and 1800 pulses producing the greatest change in cortical excitability. And more isn't and more in this case, right? You go up to these higher intensities, you start to really lose the effect, where you see out to the kind of far right that you really have no change in cortical excitability. And so there is probably this kind of homeostatic kind of ideal point, or an inverted U-shaped curve, or however you want to think about it, where, there is this interaction between pulse dose and intensity, where you can change the brain in the most kind of optimal way. And this Taiwanese group used that 1800 pulses with a submotor threshold intensity, and were able to show with a single daily application that they were able to separate from sham. So this gave us some sense of the first set of questions, which is, what does your session look like? But then the second question is, what does your inner session need to look like? And that really drew on this question of theta burst interactions between the first and second course, and how long do you need to wait? And based off of the animal data, that in order for their spaced learning to happen, you need a certain amount of time in between the stimulations. If it's shorter, then you end up with in mass stimulation. You can see that didn't really change these the dendritic spine enlargement metrics in this mouse study. But if you wait a certain amount of time, you're able to enlarge some spines with the first stimulation, and then you're able to, with the second stimulation, about an hour and a half away, enlarge more of the prime spine. So you're able to have an interval increase in the number of effects that you can have. If you don't wait long enough, only the first stimulation matters, right? And that's a really important point. That was recapitulated in that set of studies from Charlotte Nettenkoven, showing that if you wait 15 minutes, you don't get any cortical excitability changes. But at the 30-minute mark, you start to get a change in cortical excitability by waiting, right? And so the second question is this question of how much, right? And so we know the unit. we know the time in between the unit, right? And so how many units, sessions, do you need in order to produce a clinically relevant effect? And so we were, working on thinking through this. I spent some time, I called Chris when he published his first couple of papers, really trying to figure out the dose, and it's this question of, is there, the first part of it is, and there's some pharmacologists I'm sure on this call, what is the toxicity point, right? And we didn't really know that for TMS in what I would think of as like a whole, kind of holistic way. I had some personal experiences with implanted cortical stimulators, so I knew that we were giving tens of thousands of pulses for 5 years of these things and not having any kind of cognitive problems or toxicity. And so I became very comfortable with this idea that there doesn't appear to be, exciting the dorsolateral prefrontal cortex, there doesn't appear to be any clear toxicity. There's clearly a risk, especially if you've got a broad field coil or you have misplacement of your coil where you can spread to motor cortex and generate a seizure. And I'm not saying that isn't a theoretical risk here. We've never seen it, or a real risk in other circumstances. But stimulating quite a bit in DLPFC itself doesn't appear to be a problem. And this trial, really kind of zoomed in on that fact. They took the responsive people to the conventional TMS course, and they gave them, up to 16 weeks of stimulation. What they showed is what you want to see in a pharmacology trial, this plateauing of the dose response. But again, these were non-responsive individuals being enrolled into this trial. So this idea that there is actually an underdosing that's happening with conventional 4 to 6 week TMS for some people are in fact looking like they're underdosed. And so, I guess this is the video I'm supposed to tell you guys. So this is video 2. Once, and we'll talk about where the target is in a minute, but once you're in target, again, 50 hertz bursts every 1/5 of a second for 2 seconds in the case of excitation, with an 8-second inter-train interval, and that kind of pairing of the stimulation and the interval applied over 60 cycles or 9 minutes in the same protocols, 3 times as much as what you give with conventional ITBS as approved by the US FDA. And then we give that 9 minutes every hour on the hour for 10 sessions a day for 5 consecutive days, right? And I think Jean-Marie kind of hammered that point, so I'm kind of being like redundant to his earlier stuff for the group in the room. But it's important because we're using that space learning theory, and we're using that unit that I talked about earlier. And so this is just another way, and I think he said this earlier for the smaller group, this is another way of thinking about it, right? Those are 3-minute sessions approved by the FDA over 6 weeks, and so you're able to compress those like 3 days worth into a day, essentially, if you want to think about it like that. And you're applying that 10 times a day. So you're giving the entire 6-week course of approved ITBS over a single day. And so, so then we give 5 times that much. And that's important based off of the study I showed you a second ago, right? Where, that's a little bit more than, that's about 7.5 months worth or something like that. It's a little bit more than the 16 weeks that was showed to you earlier, but it's the same idea that you need that kind of dosing to really pull this off. And so then the next question is the where, right? And so we're stimulating into a cortical region, but we're really trying to access a broader brain network. We know from Mike Fox's work that the left dorsolateral seems to be a hub. If you put every stroke that causes depression on the human connectome map, DLPFC comes out as really the area that all those strokes end up being functionally connected to. So it's very clear to me that dorsolateral seems to be the kind of confluence point. And this is oversimplified for those of you that are imagers. I'm not trying to get into a complex story here. Really, the idea is that you're trying to govern this interaction between the cingulate and the dorsolateral. In normal mood, this happens, and depression gets dysregulated, and with any type of TMS, but particularly SAINT, we're trying to just re-regulate that relationship. Mike Fox and 7-8 other labs have replicated this work where the relationship between the place, the linear distance between the place that you stimulated on the cortex by happenstance as it relates to the skull position, and that distance to the ideal brain target is linearly related to the improvement. So if you use skull-based measurements and you just happen to be right over it, you have a great effect. If you use skull-based measurements and you're further away, you don't have a great effect. We use hierarchical clustering to parse out similarly behaving areas within the dorsolateral and the subgenual, and then use a decision algorithm to basically go through and find that ideal spot. So another video. And so what does that look like? You're just doing individual network mapping on each patient, right? And really what you're trying to find is this area within the dorsolateral that has a suppressive effect on the cingulate, right? And that's really the goal, is to try to find that area. Okay. It outputs to a neuronavigation system. And then, just to get back to the original video, it's another video. It gives you a sense of the kind of placement as it relates to the brain network target. So you can see in each person, the brain network is in a different structural brain area than the others. So it's situated in a different place, and it's in a different place than where the skull position is, which makes it really complicated. So not only is it moving around in the actual structural brain, it's also moving around relative to the skull, which is the way we were thinking about this before, which makes this like impossible to deal with normally. So so this is the SAINT protocol. It's just one way of having it written out. This is another visualization, And what we're doing is we're just doing a dose response curve within a consistent brain network target. The brain network target really is a way to have a consistent position to then apply stimulation in. Skip that one. So this is the first paper that we called it SAINT. We had this, I cut out the kind of the super severe stuff, but this is the first kind of non-ECT failing group. Still quite severe. About half of them had failed 5 or more meds. They were moderate, mid-30s. And what you can see is that, day 0 to day 1 is the dose for conventional ITBS. So you see a pretty striking drop at day 5, but at day 1, you see some improvement, but it's not quite, the full picture, right? And that makes a lot of sense from the data I showed earlier for the kind of extended treatment course, right? That we're really getting some improvement, but we're headed in a downward trajectory. You need more stimulation to get there. We also were able to show that BMF3 positions quite far away from some of these targets, sometimes 5 centimeters away. This is our RCT data, greater than or equal to 20 on the Madras and Hamilton, and they were at least moderate on the Maudsley refractoriness scale. This is our consort diagram. So these are people that half of them were disabled. Their average length of illness was about 9 years. The kind of mid-20-year depression load. They were, 5 plus or minus 2 med failures. So they're quite severe folks. Response rates on the bottom. Cohen-D effect sizes above 1 for all the ways you can look at this data. And these were the individual trajectories of the patients. So you can see, that they had kind of different, trajectories. We were talking about this earlier, that some of these folks, that were kind of on a slower tack, like the orange in the active and this pink in the active, were all older adults, and so this idea that maybe that lines up with some of the observations around older adults taking longer to remit. And we had some, this is a percent crossing the remission line at some point in the 4-week follow-up, and it tells you I think, something about the underlying neurobiology that if you're using this as a probe and trying to understand, is this the region that's relevant to this given patient, that you could use it as a probe to do so. So this is the MADRS change differences across these different targets. We got this FDA cleared, FDA breakthrough status, innovation funded in the US, so Medicare will pay for it now. This is Anish Mitra. This is some of his work looking at the I'm good. I still have like 18 minutes, right? Great. This is the BOLD time series in 2 network nodes. So the idea is that if you do this parabolic interpolation and you interpolate the peak of that BOLD fluctuation to deal with the kind of low temporal resolution of fMRI, you're able to pull out a temporal difference on the onset of that signal between the nodes. And what that means is you can figure out if one of them is earlier or later than the other one, right? And what's interesting about that as a systems neuroscience question is, what is driving what? What's turning on what, right? And so is there a turner on of the other thing in a 2 network node kind of interaction, right? And so, you know, if you ask this question and you didn't get like a consistent, you know, kind of finding, then you'd say, well, it's just kind of random, right? But if you can do this sort of methodology, you can see there's clearly a temporal offset that's consistent in a group of homogeneously evaluated individuals. Now, all of a sudden, you may have something real to then go and look and say, okay, well, what, you know, what is different in disease populations? So we got a ton of normal healthies. I'll show you this in a second. What we found was that, you know, I don't know, 98% of them or something, which to me is about as good as you're going to get, because somebody's not reporting their depression in there probably in 100 people. Then, you know, you get this dorsolateral that's temporally and consistently on every scan and all these, and almost all these people, temporally in front of the cingulate, right? So the DLPFC, it looks like in a normal healthy control, as per the model I showed you earlier, regulates the cingulate cortex. It has this inferred causality, right? In SAINT, after you treat people, you too, on average, have a finding of, and this is the post-scan, of the dorsolateral being temporally in front of the cingulate and the DLPFC and the insular in front of the cingulate. But that change is correlated with the MADRS in its flip in the cingulate, but not in the dorsolateral. We replicated this in 2 samples. And if you look at the pre-scan on average, there's a statistically significant difference between our depressed patients and our normal healthy controls, but also our depressed patients and WashU. This gets back to scanner types, healthy controls on a totally different brand scanner and a totally different university. And we were able to see that the same phenomenon. The depressed individuals had this lag of the cingulate being in front of the dorsolateral, whereas it wasn't. It was the reverse in the healthy, you know, basically almost all the healthy controls in both locations. And then if you take the really high responsive SAINT individuals, and you contrast them with the non-responders, SAINT receiving depressed patients, what you see is that the high responsive individuals have this finding on their pre-scan, and the people that don't respond to SAINT, they don't have it. They look like a normal healthy control. So you can look at that, you know, A and B, and you can see it looks a lot like A and B there, right? And so it's this idea that I'm not saying that people that are not SAINT responders are not depressed. It's just that they don't have this particular network arrangement, right? They don't seem to have the kind of network pathology that is being evidenced and perturbed here, right? And so then there's no change on their post scan. And what's really interesting is it gets back to like the diagnostic heterogeneity question, right? Is this question around, well, is the presence of the lag correlated, you know, with severity, right? And so it goes up as the severity goes up. I would argue that the diagnostic certainty goes up as the severity goes up too, right? We're much more comfortable with people with saying, somebody's depressed when their MADRS is a 25 or a 30 than we are when their MADRS is an 11 or something, or a 14 or whatever, and so it's one of these things where that's reinforcing as well. We also did pilots on suicidal inpatients. This is what John Marie had a big role in helping with. This is the next phase of this, and the study's ongoing now, but this is kind of the piloting of it. And so we ran 12 people in open label fashion on the inpatient unit. They had like an average of 2 hospitalizations, 1.5 suicide attempts. And this was their kind of pre-post. And then we retrospectively matched with ECT patients, with the same severity and treatment resistance and gender and all that stuff, just to give you a sense of the speed in which this can happen. And then we looked at the SSI score, and you can see that and we've seen this, we knew this kind of before we did this trial, we were seeing this, but then kind of confirmed it, which is the suicidal ideation really is the first thing to go, which is really useful, right? And their depression improvements, lagged this by 2 or 3 days. They were still very depressed when their SI was gone. But what they would say is, oh gosh, I can't believe I haven't thought about that in a while. It's like a removal of kind of phenomenon. And then we followed them out to 6 months as far as the SI reductions go, and it stayed pretty stable. There have been other attempts, early attempts. Chris, Paul Holtzheimer, Mark George were all major contributors, to the early work of saying that this can be done, and saying that it looks safe, and saying that people are tolerating it. More recently, there was a study out of Penn where they were, essentially completely trying to replicate us as much as they could without using, our exact processing algorithm, but they used the same scan types and all that good stuff. And they were able to get statistically significant improvement over sham. And then, this question around, do you need the targeting? So this is a BMF3 targeted accelerated protocol, 20 people or something. And, everybody was like, we can just ditch targeting. But the problem, I think, with that whole story is this is an open label study, and this is highly now in the media, and patients are aware of it and all that. So I think we've got to make a lot of these decisions with truly fully blinded trials that are actually blinded and all that stuff to really know if something works or not. And so that's one of the big questions over the next couple of years is, which type of targeting, does targeting matter or not, or whatever. And we've got some signals around that that we'll have by next year. This is all the folks that have worked on this, the group, and just really appreciative. Jean Marie was very central to a lot of that work over the years that he was in the lab, and was a superstar postdoc for us, and just really appreciate all of his hard work and help through planning many of these trials that are ongoing now, and to the group that's here that's really working on the next steps. Thank you all as well. So happy to pass the mic to Chris. Take questions now, whatever makes sense.
Thank you so much, Nolan. I think we will. Please stay close to me. Thank you so much, Nolan. It's a very great talk, and having all these pieces around how you the creation and how you build the same protocol is really insightful, and I think that so we will keep some questions for first Chris, and now this is I will pass the mic to Chris, and to discuss a few aspects you wanted to and key aspects of the same protocol, and then we'll have the discussion to the audience. Thank you so much, Chris, again for being there, and so Nolan, you are
So you're very welcome, Jean-Marie, and thanks already to Nolan for his excellent overview of this Saint or SNT protocol. What my role here today will be is not being the second moderator, but I want to focus a little bit further in on the origins of the accelerated TMS protocols, where it started in Europe at some point. It started already more than 10, 15 years ago when we were thinking about that. And then I want to focus a little bit more on some of the more specific questions. Some of them Nolan already touched on about, but this is the first time, in fact, that Nolan and I will have this debate, and it's a debate directly, a debate or a discussion or a talk on online. And I think Nolan, we should have done that more before. Certainly, if I'm looking at the evolution of your work now. But maybe first to introduce a little bit the talk. It's not that long, I hope, but I want to set a little bit more the early years of the accelerated protocols. I have nothing to disclose. I will overview briefly the accelerated TMS of the beginnings and also the ideas and origins that when we started with it, what we wanted to achieve and how it has grown further now to a fully FDA approved SAINT protocol, and hopefully that a lot of these severely depressed patients can benefit of that. So I think this is more or less the part. I will focus a little bit more in I think a few relevant questions. What I would like to have Nolan his brain on or his idea on, and of course it's always about number of pulses, session intervals, that connectivity, that distance, what is the indication, the long-term effects, and I hope that we have done an open discussion further on. But I want to set a little bit the lines how that this discussion can go. Let's start with part one. So as we all know, and I think we have the TMS already for 3 decades now for depression, and it's just good to remind ourselves that it's also in the European guidelines of Jean-Paul Lefaucheur from 2014 on already as a level of A of evidence, of course, to treat patients with major depression. If you do it high frequency, low frequency, bilateral, if you do deep TMS, if you target the LPFC, the MPFC, the idea is, of course, and this is the focus, you have to have multiple sessions. This started years ago, and it's on a daily basis that you have to treat them, and weeks at least to have some effect. And already in 2009, so that's already a long time ago, there were effect sizes who for the daily stimulation protocols remain more or less the same. Roughly, you have an effect size of 0.4, meaning roughly that 4 of 10 patients will respond. At the time, in practice in Europe, it was really seen, oh, that's not that good, only 4 of 10. But of course, we have to think that these are already done in groups who were treatment resistant. So this was not that bad, but there was a lot of not so much enthusiasm for TMS at the time. And if you're looking at the difference between the world, more or less, that you see that TMS now is very much used in the United States and maybe also in the Anglo-Saxon world. So these are only some images made by ChatGPT, just to say make an image of, and you see these very strange modules. And I think still in Europe, it's perceived that it's some kind of a strange device doing whatever, and you see that you have more or less or very few TMS growth in Europe. Even you can argue that it's mostly due that it's non-reimbursed, of course, and this is the major difference between the Anglo-Saxon world. The other part is that we have in Europe, maybe a bit different as in the States and Australia and New Zealand, that the use of ECT is always been the golden standard. So that means that when I started in 2004-5, and I wanted to have some kind of introduction of TMS in our psychiatric societies, we always had the, let's say, the not the combination, but the balance between what is best is now ECT of TMS, and it's always ECT at that point because we never had these figures from 80 or 70 or 80 response or remission rates that we see with ECT, certainly within psychotic depression. So I guess at the time we were always, and I think this is worldwide, as psychiatrists, we were interested how that we have to improve the response, but certainly the remission rates for a depressed patient, because response, of course, is fine, but you have to have them in remission because, of course, as you know, if you have some residual symptoms, relapse cannot be that far. And in the line of 2004, when certainly in Europe was the idea, we have to go as close as possible to the electroconvulsive therapy outcomes. And if you think about it, of course, you have severely depressed patients who are in remission after 6 to 8 of these sessions of ECT. So it has to be something that we have to power up immensely. When I started, the golden standard of daily TMS sessions was 10. When in 2012, 14, I think, there were already the golden standard was 20 sessions. Now we are seeing 6 weeks or even more. But the idea, of course, is instead of mounting up that number of electricity over a lot of weeks, why don't we focus that over a couple of days? And this is, of course, of interest of a patient. Patients are more interested to come let's say 5 days to your clinic or hospital, then have to do it for a month or nearly 2 months. And also somebody needs to apply, of course, this TMS device or these TMS sessions, and concentrating maybe would help a lot. So we started of that, and as Nolan said, the pioneer study is the one of Alzheimer. We thought that was very interesting. And the interesting part is, even if it's only an open label study, that you see only in 40 patients, severely depressed patients, but dramatic decreases after 2 days of stimulation. So these were 15 sessions in total. And the interesting point is that it was not only the same response or remission figures that you got from the daily sessions, it also endured at least a couple of weeks, meaning that the effects were not very temporary and they prolonged a bit. And I'm just going to overview a couple of our studies when we have started it here. There are some crossover studies with high frequency TMS and also with accelerated theta burst stimulation. And at that time, we opted for the 20 sessions because this was the golden standard. And instead of doing that then in 20 days, we are doing this in 4 days time. And our protocol at that time was based on 5 sessions a day, 4 days in a row, and the intersession interval, what also will be an important discussion point, I guess, was 15 minutes. And how would people ask, how did you choose this? It's a very banal or a trivial answer. This was the time, because we didn't know about the Huang papers at that time, the Netterkover papers. This was the time that we could cool our coil in the freezer, and that was a 15-minute time. It's very trivial, but we started with that, and in fact we still continue to some extent with it. And in our first trial, it was a randomized controlled trial with high frequency TMS. The importance for us was to see if we could get the numbers of remission and response higher up, and this is a placebo study, and we found that 35% of the patients and at the end responded, But importantly here, they were also in remission. Now the 35%, to be very honest, was a little bit of a disappointment for us, because we expected, of course, what we see now with the SAINT protocol or the SNT protocol, much higher figures, but also these patients were very, very severely depressed, ECT non-responders included. But the 35%, if you were in remission, a response, you were in remission. And importantly here, we had a lot of imaging results to examine neurobiological effects. I'm just showing you some of them, where we did find that the functional connectivity between the subgenual ACC and the left DLPFC, the more anterior that you are, the better the outcome. And those who responded, the connectivity reversed. So this was some kind of an effect that you found in the responders as in the non-responders. Following our PET study that you see in the middle in red there, we focused again on the subgenual ACC, knowing that, of course, from the Mayberg papers, that was not only an important hub in emotional regulation and depression, but it's also one of the few biological markers that we could use at the time, that we saw that those with higher metabolic activity there could be the responders. And if you respond, it would decrease that metabolic activity. And it is not only something that you see with TMS, but it's also something that you have with medication or even with the brain stimulation. So this was more or less for us some kind of in line that if there is a biological effect, but there is a biological effect over 4 days. And the latter study was just at that point also not only a feasibility, but also a safety study where we were looking at spectroscopy, just to look that we wouldn't find any neuronal deterioration under the stimulation core, which we didn't. And we found some effects on the GABAergic system. But this is a little bit too much detail. Then we switched over, as also Nolan mentioned, on to accelerated theta burst stimulation, to even give shorter periods of stimulation, which could benefit even more. We have seen from the Bloomberg study that it was quite similar than the high frequency TMS. So we kept exactly the same protocol, but we did it in accelerated theta burst stimulation. The unfortunate thing was that we saw that there was not such a good response directly after, but we had some delayed effects, where we had then 30% of response and remission respectively, but the effects seemed to be delayed, so we couldn't find a direct response. And the effects were more or less in line with the high frequency TMS, but also we found neurobiological effects which were more or less in line with other antidepressant treatments. We did find again that functional connectivity change. We did find changes in perfusion when you get better, coming from a depressed to a more non-depressed brain. And what you see also in red was for us also some biological proof that if you have a successful active TMS, placebo, you didn't find anything. You did see an volume increase in the left dentate gyrus, where there is, as you know, some possibility of neuronal growth again. And we corrected for an whole brain. We did find that particularly in that region, and also those patients who had sham first. Don't forget, it was a sham controlled study. We did the active effect. We found exactly the same. So there were some neurobiological effects that we could say at that time. So it was quite safe. Those accelerated TMS seem to be well tolerated. If you respond, then you're nearly going in remission. And the theta burst had some delayed effects. And of course, the important thing is that it was accompanied by neurobiological changes, which are in line with daily TMS, with even electroconvulsive therapy, the brain TMS, and medication. So the time gain, instead of going for that 20-week or that that 4 weeks, sorry, or that 6 weeks, we could find it already in a couple of days. So this is, I think, one of the major, let's say, incentives for us to carry further with this accelerated TMS research in depression. But still, of course, how to improve response and remission, because we now have the same effects or the same clinical outcomes that we see with the daily. So this is fine, that time gain, but it was not really coming close to the electroconvulsive therapy outcomes. So Nolan already talked about this, so I'm going to over this very short. So this is the first study of Nolan where he had these huge effects in these severely depressed patients in a small open label. So you know they did a follow-up open label study, and you had remission criteria and response.
Oops. We lost Chris for. We still have his slides, though. Oopsie. Sorry about this interruption, but I guess we have a few minutes break until Chris is back. Maybe there is something going wrong in Belgium. I'm not sure. Oh, Chris is back.
I'm sorry about this. I seem to lose the connection. So sorry about this. I'm going further with my talk, and you know as well that even in that small randomized controlled trial of the same protocol, they still find this. So this is a repetitive finding of high response and remission rates. So the conclusions are coming more close, and this is an important thing, I think, and we're talking about mostly Europe here, that we can going to our colleagues saying that we have a non-invasive stimulation method that at least can compete with these electroconvulsive therapy findings. And this is not trivial. This is, I think, certainly for Europe, a very, very important finding here. So I'm going to part two, and these are some of the questions that I have also around the next steps and also the SAINT protocol, how that it will be evolved. And of course, I have a question about the number of pulses, the number of sessions, and the number of sessions intervals. And I think to introduce the question a little bit more, and Nolan already alluded to that we need, of course, to substantiate what these findings are. We need larger prospective studies, and we still have to have some answers, I think, where we have to go further. And so what we have done, and it's just quite a new finding here, and I think it's worthwhile to discuss it. We have used around 1620, around 1500 pulses in our accelerated paradigms. Nolan has demonstrated why he has used 1800 pulses per session. But you know, of course, the other FDA approved protocol from the group of O'Riordan at the time, they were using 3000 pulses per session. And we had the idea, and this is in preparation, this is new, so we have the analysis just done, but I think it adds to the discussion here, and we hopefully will submit it in the week to come here, that we have done another accelerated theta burst trial. It's a between subject design, so we did not a crossover here for 68 patients. And the only change that we have done is going from that 1500, 1600 pulses to these 3000. The idea at the time, it was also before the SAINT protocol came out, if you want to engage in more response and remission, and it would be more like ECT, we should make it more powerful, and that means that we should increase the number of pulses per session. So it's a between subject design. It's only here to show that those in sham, we are not going to talk about this for let's say ethical reasons. They did receive then the active afterwards. We have a gender and female is more or less equilibrium. Most of them came on an ambulatory basis. All kinds of people were included, mostly right-handed people. And we did find a statistically significant decrease of the active as compared to the sham stimulation, again in the delayed outcome. So no immediate differences, but delayed statistically. But now the thing comes. If you were looking at the response and the remission rates of that group immediately after the active, we only found 3 to 9% response and remission. We only and it was even less than in the sham group because they were even higher. We also looked at the delayed effect, so that means that this is our end outcome, and we only found in this group 12% of people who responded and only 6% who remitted, and we did not find then a placebo remitter, but some kind of a placebo response. So this is and I find these are new findings only based on the number of pulses. And of course, now the factor is, and I think this is what I would like to have also in his thoughts on everybody, of course, but certainly here in Nolan. What is now the driving factor? Is it the number of pulses, the number of daily sessions? Okay, we can talk about the sessions interval, but doubling the dose in accelerated paradigms with 50 minutes intervals with all its limitations, but if you compare and exactly to the same groups, large, you don't find any. It's like a statistically sound finding, but it's not really a meaningful clinical finding. And I think this is the first question that I want to ask then. What is the driving factor? What you would do different with the SAINT protocol? Is it the one of the three parameters? Is it all of them? What are the thoughts here?
Yeah, thanks, Chris. Yeah, I mean, and thanks for showing us this new data. I think it's tough because we made a bunch of, I think, very thoughtful, what are ultimately like engineering designs, but not. It's one of these things where, in my view, it's impossible to like 100% sort each of these out because you have to do essentially knockout experiments on all of them. Like take the SAINT protocol, change one thing, run it against sham, take the protocol, change one thing, run it against sham, and iterate until you find the necessary components that make it. And I'm not convinced that you can do that with a TMS device, and so we've actually, and I alluded to this in my talk a little bit, but we've actually been very focused on this idea of, and like poor Jean-Marie last night had to deal with me like for 5 minutes at the end of dinner, like communicating with one of my postdocs. But we're trying to build a direct electrical device that can recapitulate the exact kind of effects of TMS electrically, and then if we can get it to work, step one is to get right and actually this kind of lateral relation.
But won't you, because one of the interpretations that we are thinking of now, I see your point, is to say, okay, maybe that number of pulses going up to more than the 1800. I know that you have shown that on the motor threshold there from the Netikov study, I think. We are thinking, why don't we just do the Huang 600 pulses and do it then instead of 5 times, maybe 10 times, maybe we just have to reduce that. It has not, it has less to do. I'm going to be very careful with my words. It has less to do with the number of pulses per session, but maybe it's the number of sessions that is of essence.
Yeah, I mean, that's the you know, that's kind of what I was getting at. I mean, I think it's one of these things where like we kind of just made these decisions, and then we've gotten it to a place, and then we have taken the that we don't know what the therapeutic, I don't know, it's therapeutic index, if you will, what the therapeutic index is on each one of those design decisions. You know, so I'm limited in my ability to tell you, as you know, because I haven't published any of this, a completely prospective scientific rationale for any of the decisions, right? I think that because we did, you know, daily, you know, ham sixes or whatever, now we're doing daily madrasas, we can get a good sense of the number of days. I'm pretty clear on that. It's pretty variable across people, you know, but the idea that, you know, the question of whether or not it's you know, a certain number of pulses per session or a certain number of sessions or a certain intersession interval, which I think all interact with one another within a given brain target or not, ends up being one of these things that's just such a hard set of experiments to run. I think it would take 10 years to do it. I've given up, to be honest with you. I've given up on the idea that somehow, again, with a TMS device, that I personally will be trying to iterate all that. I think if you've got an implanted device, it becomes much easier to do because you can just set it and have an AI algorithm search across the search space. If you've got something that's kind of able to be programmed iteratively over time, you could really work a lot of this out. The other piece is, and you've done a lot of like the neuroimaging biomarker side, but what we really need, and Martine Arns and others around, is this idea of having a real-time readout. You have a real-time readout. Yeah.
I agree with you on this. I think one of the next steps, and I think a lot of labs are thinking about that. It's not only the brain state, but it's also that closed loop system when the brain is more receptive to maybe less long stimulation, but more profound. But that I agree totally with you that then we are another 10 years of research doing that. But this would be indeed some next stage to get it. There are the reason why I ask it also, and I see some of the questions are also in that direction, is of course some people, if they ask me, also patients, they say, oh, 10 sessions with 10 with 50-minute intersession interval, that's a longer time. What is able to reduce that? And I think the question is also from a practical view, and I think some of the audience is asking that as well. We can talk about it more in detail later, but also how to reduce the timing. Is it possible? And I think this is the realm of the discussion here.
Yeah, it's a great question. So we've never had an active, we've had, you know, 1 or 2 sham patients in the trials, but we've never had an active patient quit before the 5 days. Our like retention rate on people actually getting active when we get through these trials, end up unblinding them, is essentially 100%. And so, and to my knowledge, in the early rollout of the kind of full-on clinical commercial rollout for this, I'm not aware of a single patient, and I can go check back on this, that's dropped out due to the schedule. I think that it has, and so I've had a lot of people have a very different, and that's, by the way, not me, that's like 8 other clinics in the US spread out all over the US, so it's not just me saying this. I think it has more to do, at the end of the day, with the presentation of the information to the patient than it has to do with the actual treatment protocol itself.
Mm-hmm.
If I say to a patient, hey, I'm going to get you a, whatever it is, 70, 80, 90% chance of your cancer going away, if we spend, 90 minutes a day spread out over 10 hours for 5 days doing the surgery, or I'm going to have maybe or maybe not a lower percentage with another protocol. What I find is the patients are saying, just give me the full Monty. And in fact, like I've had early on when we first started doing this, I had a couple of patients who remitted the first day, particularly younger patients. And I was very worried about that, right? Because I was like, gosh, these people are totally well, and they're, I can't imagine giving them 4 times as much as what I just gave them, whether or not I'm gonna have a mania risk or whatever. And so I went to every single one of those people and I said, hey, I don't know, you're well, you should just stop. I don't know what relation would do. And I was actually trying to get them to stop. They wanted wanted every single session, all that kind of stuff. So I think and everybody said this to me, particularly at the beginning. Mark said it to me. Everybody said it to me. That this is, and I think it's actually more a doctor problem than it is a patient problem. I think.
Well, if I may, I agree on that as well. The only thing that I could see as some kind of a problem, there are two sides. A problem, practical done, it's not a problem, is that there are two sides. You have to go for the full Monty, so that means that on the one hand, you will have the patient to say, okay, no, this is the protocol, you have to follow it correctly, because otherwise I will not do it, or will not pay for it, or whatever. And then, of course, you have the facility itself that has only the capacity maybe to do a couple of patients as such. And that means that at some point you only will reach maybe a limited amount of people there. I think it's also in that, with that perspective that these questions are sometimes posed. I do agree with you fully that I think on a patient view, if you say to somebody who's been, I have seen patients like that as well, if you are depressed for years and nothing helps, if you have 5 full days, or that you have to be there, as compared to maybe trials for another 3 to 4 months to half a year, everybody will agree on that. I don't think that the patient and but the thing is, what I want to say, the patient will not, I think, want you to deviate from the protocol, because if you deviate, then it's not a protocol. And so you're a little bit stuck, I guess, between the practicalities and about the methodology that you use, with few degrees of freedom left.
I agree with you that not every place is going to be ideally set up to do this, in the sense there's going to be places here and there. What I've been surprised about is in like the post clearance kind of phase 4 like trials that Magnus has done. They've been able to do this in a lot of places that were prior practices. But the real driving force in the United States, at least, that being much more on the side of, is there money for it? When you talk about facilities and the ability to do it, right? If there's enough money to pay for it, the hospitals find a way. And if there's a way for a hospital to be not losing money, but even like making money or breaking even or whatever it is, where it's not like a scenario where there's this huge cost sink, and you can show that on balance at a certain point in time that treating and getting a certain percentage of these people better actually reduces downstream costs in the system, or costs of, like life years being dwindled away or whatever it is, then you end up being in a scenario where on balance, then you can actually justify it. And so in one of my slides, I showed that Medicare is now paying for this, right? So now Medicare is paying specifically for the same protocol, and they're paying, at a number that even right now, before all the advocacy work, whatever, ends up being enough to kind of probably break even for a lot of these places. So it's one of these things where their if their financial infrastructure is there, to support it, I think that it doesn't matter what it is,
Well, maybe going further on that point, and I'm talking a little bit more as a European here. So this this is some kind of difference. I think what some people ask me as well for the protocol, and is some kind of a bottleneck, is the connectivity. You need to have the fMRI, and I'm going to pose a little bit a challenging question on you, Nolan.
Yeah.
These are some things that we in Europe we can ask colleagues. Yeah, but we don't have the fMRI. Should we need it? Should we need it? You have already talked about that, I know, but I'm going to pose a more challenging question to you.
Sure.
It's not a malignant one. It's a challenging one. So.
Right.
So we do know, just to introduce that, for years ago, we need to have neuronavigation, the right stimulation spot. In effect, we have no idea exactly on structural where we have to stimulate. We have no idea. And the Fox paper that started all that functional connectivity with the dorsolateral prefrontal cortex has a more personalized target, as a lot of us are investigating, doing research done on structural and functional ways. We had also Debbie Closer from our group had also a review on it from EEG and on fMRI, and I'm just going for the fMRI party, that it's indeed for the to reproduce, if it's something that you can use, that we do find that the DLPFC functional connectivity and network has apparently some merit in using and having a better outcome responses. But probably also the ELBOW study saying that, of course, if you have a lot of patients that you're doing, the additional value of the target is only 3%. So in very large sample size, you have a lot of problems with that, and you see that in the maybe better in the smaller samples. So making it maybe
it's important to kind of zoom in on that. There was only a 20% screen out rate for 3D.
Right.
So there was people that are really looking at we're looking at this now. There are people that are really looking at this now. I don't want to, but I think that there's data out that it's going to matter. It's going to matter that you've you're not taking the broad catch-all depression group, but that you're actually probably subsampling a group of people.
Okay.
That MDD. I think that's going to be what, since if everything's published, and what I'm hearing is, that when you get down to brass tacks on having, a more open or a more narrow group, that the people that have, clear MDD kind of face validity, well, you're going to end up finding that it's, I think people are going to end up finding it's going to matter more. And then when you have a group that's, and there's not it's not even a critique of 3D. I'm not critiquing it. I think, in some ways it's a statement of how generalizable 3D is, that when you have that big group, then it's going to be harder to get one subtype, biological, biotype, whatever you want to call it, and I think that's going to be the real question, because there's kind of two scenarios, right? One of them is, it is, as you present it to be, there's 3% or whatever it is, there's some kind of low explanation of the variance. It doesn't really align with the other study findings, but when you talk to those guys, say these are really clearly kind of phenotyped people that they were looking at, where it's a much stronger effect. or the second one is that, right? That we need to, as a field, kind of zoom in and you know, being here at Salpêtrière, I'll say I'm in the spirit of it. You know, I mean, you know, this idea of idiopathic Parkinson's disease was born out of these observations, right? That there is Parkinsonism that can happen across a lot of different illnesses, but there's actually these kind of distinct clinical phenomenon that we now call idiopathic Parkinson's disease, Lewy body dementia, progressive supranuclear palsy, all that kind of thing, that we used to lump as a bunch of people that had resting tremor. And so I think that that's more, in my view, what it is, that I think there's going to be a finding that in a subsample, this target ends up being really important, right? And in the broad catch-all kind of umbrella term of depression, you may lose some of it.
Well, I think, Nolan, I agree with you. I think these you're referring also to the works of Shan Siddiqui, for instance, with these different networks and different phenotypes of, and I think we have to do that. But for the accelerated paradigm, I want to go one step further because, and I want to ask you the following, because we found it, these amazing studies, of course, very interesting. But if you're looking at the targets, the individual targets that you have selected, and we were very intrigued by that a couple of years ago, it seems to be that they were, I'm not saying clustered, but they seem to be, as you said, not the F3, the beam F3, but it seemed to be quite close together, and of course there is no problem for that. But if you're looking a little bit closer to that, and this is a little bit, I said what is maybe challenging, or what your thoughts
Sure.
about is here, that we thought, okay, if you look at it, you're maybe not really in the dorsolateral part, but more in the ventrolateral part.
Yeah, no, it's a great question. Yeah, so
we just to finish this, we made some kind of retrospective. Okay, it's a retrospective study that we looked at our PET data from our accelerated data before, with PET more stable than the variability that you find with resting state. And we did find that those who were doing better, even if you have stimulated not the ventrolateral part, it seems to be that these patients were doing better, making for us the idea that the stimulation, maybe with accelerated paradigms, it's a little bit of pity that you don't see the images here of the visualization of it here, that instead of going it from the dorsolateral prefrontal part to the subgenial, where it's probably problematic because there are no direct connections, but maybe if you target the ventrolateral prefrontal cortex, you have a more direct contact probably with subgenial ACC. And if you think about it, this is exactly this ventrolateral part that we stimulate with electroconvulsive therapy. So I was wondering, and this is of course a very, very a broad question, and I do agree that you have depression subtypes, and it will not be all explainable like this, but to bombard with the same protocol the ventrolateral prefrontal cortex, aren't you coming maybe more close to that ECT outcome? And then is the question, will it matter then that much if you first, if this is the reason that you need that fMRI? And secondly, is it then of that importance if you have some subtypes, and maybe a lot of subtypes will respond to this kind of high pulse dose, as you explained, to that. So it's a little bit of a challenging question here. And the reason that I ask is as well, because if we do need the fMRI ultimately, couldn't we do that as well with other images, that it makes more accessible and I'm talking again in Europe for a lot of more patients, that we do it, for instance, with EEG, that we can come to the same conclusion. This is a long intro for for a question, but I wanted to make my point very clear what I wanted to say.
Yeah, definitely. Yeah, and thanks for your question, Chris. Yeah, so what's really interesting about definitions on masks, at least for Brabant 46, they're extremely, like the Venn diagram of a mask, on where you get your atlas from, ends up being like 20% overlapping, which when we figured this out, we were just like, crap, like we really not think that, you know, that like we thought that the mask definition off of a given atlas was going to be 90% overlapping or something like that, but it's not. And so when we got into like the brass tacks of the whole thing, we realized that, so one person that helped kind of build the pipeline and the original go at this picked a mask. We then kind of went back and looked at all the masks, and it was like, oh, well, the masks are quite different across all of them. You know, we're using the mask that recapitulates all of that. So it's like one of these things where it very well could be VLPFC, it could be you know, lateral, you know, anterior, lateral, posterior, Brabant 46, DLPFC, depending upon. So it's a definitional thing. I guess in my head, pragmatically, it scientifically, it very much matters. I don't want to discount that. I think your question very much matters. Pragmatically, it's the space that the mask defines based off of that atlas. And whatever that is, right, which is very lateral. It does not sit where, to your point, where it normally sits with BMF3, which is essentially at the eyebrow, edge of the eyebrow line up on the hairline, right? That's where normal BMF3 sits for everyone, right? Like this is more lateral than that. It's sometimes more anterior to that. And so, so yes, I agree with you that it is definitely in a very different region than what we normally think about as the DLPFC target, whether it's, you know, in order to actually do that, you need to do the mask and then do these kind of anatomical studies, whatever, but, you know, and try to back validate that or something, you know, and so I'll leave that to the anatomist to deal with as far as, is it Brabant 46 is defined by this mask? Is it VLPFC? I think it is, you know, it is that region that we consistently.
Yeah, I agree. Yeah, we need to follow up on this. I think we have 20 more minutes, so I'm going very fast over remaining questions that I put onto the table for, let's say, inspirations for the audience. So, of course, you have talked about the higher intensities that you see with the daily. You're using indeed the 90% that scalp to distance. So the question, I think, for some of people could be, the DLPFC and the motor cortex are not quite similar. So how to define this 90%? And you don't have to answer.
Well, but
you don't have to answer now. I'm just going through because I promised Jean-Marie that I will stop.
Yeah.
I will stop here.
The 90% is depth corrected, right? And that's cited.
That's depth corrected.
So,
yeah. Yes, of course. And what is the philosophy after that? The other question, of course, you have the recent paper that it's very interesting that if you do relapse, that the restart of Saint is very effective again. So this is very encouraging. You have some things already said about long-term effects. I think some people aren't going to be interested how do you maintain it. We have talked about different trajectories, of course, and the phenotyping of patients. Maybe they are different to the Saint protocol. There are some trajectories, as you know, for daily stimulation. They seem to be more or less consistent with accelerated protocols. Do you think, of course, this is the same for the for the same protocol. What does the trick? Is it parameters that have some more weight for you? Is it the entire package that you still need? We have talked about this very shortly, but I think we are going to part 3 to the audience, and I think it's up to the audience now. If there is some need to answer one of these questions already, Nolan, please feel free. But I think now my role I have fulfilled. Thank you for this interesting discussion. Thank you.
Thanks, Chris. Good to see you, man.
Thank you so much. So yes, I guess that we are about to wrap him up, and with this the question from the audience. So guys, feel free to bring up any questions, and also we have a few folks here if they have.
There are several questions in the chat. I have to say.
Okay. So already several questions. So one question. After finishing the same protocol, is it better the patients come back for the same session for accelerated TBS after about 3? I guess this question is about maintenance, and I think it echoes with Chris's remaining point. And what do you think about the lasting effect and how we could, maintain the saint?
Yeah, and I'm sorry, I thought I had that slide in the deck, but I didn't have it, but I'll tell you about it. So we, I did not, but Brandon Bensley worked out a way to use a wearable to trigger, to essentially actually just predict the clinical MADRS score. So the wearable predicts the clinical MADRS score. The clinical MADRS score prediction triggers an actual clinical MADRS score. In this study, the actual clinical MADRS score triggers or doesn't trigger retreatment. So it's like this kind of like, people are trying to develop closed loop systems. This is like it's not like a super long closed loop, but it's not like a closed loop at the temporal resolution of a pulse. It's a closed loop at the temporal resolution of a couple of days, which it pragmatically is actually seemingly very good. And so what this does, it says, the person's headed in the wrong direction in a consistent way over this period of time, trigger this clinical MADRS. The MADRS happens, and then the clinician decides to come back in and to retreat the person. That's the idea, right? And so with that, we've been able to show that we can keep people well for a year with a day or two of stimulation and not needing the whole 5-day course. And so this is particularly interesting because, as you all know, historically we're waiting until people relapse and then we're having to do a full course again. And so this looks a lot more like maintenance CCT works, where you're actually giving essentially a prophylactic dose. And what is really interesting about that is it looks like you only need about 1/5 of the dose to maintain people. And so this and getting back to the earlier conversation of like, this is really heavy and all that. Well, what's cool, right, is that if you can get people out, then the amount of work that it takes to keep people out, in the sense the amount of dose, is a lot less. And so 5 days over and over again is a lot, and it's kind of hard to think about logistically and economically, but 5 days once and then a day on average every 2.5 months, that actually, in the scheme of things, is not that bad. And that's what we're seeing, is once you get people into that state, keeping them doesn't require a ton of dose. And so we're really excited about that, right? And that may be the way, just like with dialysis, you have this very expensive acute hospitalization during an acute renal failure episode that ends up, or acute and chronic or whatever it is, that ends up necessitating lifelong dialysis. But then once that happens, to keep the person out of, renal failure kind of symptomatology and all of that is not as much dialysis, just a little bit of dialysis, right? That's the model we think we can kind of pull off, is using a lot less stim to keep them well.
Thank you, Nora. Yes, so definitely was very interesting. I like this idea to giving people some prophylactic treatment and make sure that you can maintain. And this is something that is particularly new in the field of antidepressive treatments, is the fact that you are able to to dose and to have a rapid acting effect antidepressant, and you can even in addition to those the number of pulses and sessions, you are able also to make a call on when to deliver this. And I think that's particularly of interest to have a look at this maintenance protocol. One question that is related to the maintenance protocol, and Chris, feel free to intervene. But one question, and this is one question from the audience, is that do you have data? And I know that Andrew published that in his priority data letter, but about different profiles of durability after same treatment. And do you have any comment on that, please?
Yeah, I mean, we so we're running some trials now, and one of them is taking into account the durability out until people relapse, which is not what we did last time. We just went to 6 months or whatever. And so the data now is looking really good. I mean, I actually think that our durability on these in one particular trial where it's a kind of the full-on 50-50 active sham Saint replication trial, the durability that we're finding, some people are getting a year and a half or something like that, and so we've seen a lot more of that. They're also not as, the people that we enrolled this go around aren't as acutely sick. They're just as treatment resistant, I think, but they're not as acutely emergently sick. So they're more stably TRD. And so we're not seeing as much of a quicker relapse. And that's kind of one of the things that we've figured out, is that people that are in more of an acute on chronic illness, they will get well, but they'll relapse faster, and then they need more dose. So you need to retreat them, which doesn't end up being a problem clinically, but it's harder as a clinical trial population. This population that we've studied more recently is more of a stable, nowhere near needing to go to the hospital, but sick and TRD. So
maybe there is something that it's worthwhile to discuss, and just to be that we have to be very careful for one thing, and that's about the suicidal ideation. Nolan mentioned it already, that you have, even if patients are still depressed, they seem to have less suicidal ideas. This is exactly what we have found in our first ITBS study. This is kind of the same direction that also the group of Mark George found. And that's with, you find similar findings with the active stimulation as with the placebo stimulation, meaning that for a lot of people in these kind of protocols, it seems to be that suicidal ideation lowers. But I think it's too early to attribute the effects of an anti-suicidal effect to the real stimulation part. We have seen also in imaging, also placebo effects on suicidal ideation that we can explain by just people having less feelings of hopelessness, because there is something that's going on. It's also remarkable, and that's also what Nolan shows, for a longer period, even if you do not get better, it seems to be that you have some kind of prolongation effect on suicidal ideation, some kind of protective effect. But I would be very careful for going to the idea that because they asked us as, oh, if it's so good, come to the emergency room and we are going to treat all these all these suicidal patients with accelerated theta burst and they're feeling better. Of course, there is that rapid acting idea that we have from the ketamines. But that's my opinion now, Nolan, and this is something that we should be here for accelerated paradigms very careful to I'm not saying that we advocate it, but that we should be very thorough in this, how that it comes, that people feeling better and not better have less suicidal ideas. Potentially, there is some kind of a placebo effect working here. But this is an opinion, but I wanted to have this out at least for maybe a 2-minute discussion.
Yeah, our original RCT, we separated from sham on the SI measures, and so we were actually statistically significantly more anti-suicide effects on the active compared to the sham for our data. And we haven't, knock on wood, we haven't had anyone have, in any part of any of our trials, a full-blown attempt getting active, or in any of a follow-up periods. And so to date, we haven't seen it. And so, as those of you that are seasoned clinical trialists go, that's not to say that it's not going to happen. It certainly could happen. It may happen tomorrow, but it's one of these things where at least, to contrast that, there's an FDA clearance for esketamine in the United States. That FDA clearance, or the FDA approval for esketamine, includes an approval for suicidal depression. There were 8 deaths after the esketamine trial. It's in the guidance document for the FDA for esketamine. 4 of those were suicides. 4 of them were indeterminate. One of those people drove their motorcycle off a cliff. So I think that in the scheme of things, with there being like nothing other than esketamine approved for suicidal ideation, it is a worthy area of study. Jean-Marie did a lot of great work in getting the initial like RCT designed for us, and that's going on now to answer the question that you're asking, Chris. And so certainly nobody is saying that you should treat suicidal ideation with this until that's a positive trial. The FDA's made that determination, but it's one of these things where gosh, I think the alternatives aren't great, and so I think that there is a world where this certainly has the potential of being used in that setting, and makes a whole lot of sense to be able to use it, given that our best alternative esketamine is that the finding that led to that label expansion was a single time point, 4 hours, and so which to your point is a big problem, because people leave the ER at 4 hours after they were to get something like an esketamine or whatever, and then they end up being in a scenario where then they're at home and they're at risk again, So it's one of these things where, to your point, I think we've got to be really careful as a general field about this issue, and that a lot of funding needs to be kind of poured into something potentially.
Well, of course, what the difference could be, of course, that the trials are needed. I agree totally. But in the trials that we have done, and we see the suicidal ideation going down with or without, and the effects on mood or on depressive symptoms, most of these patients are not acutely suicidal. And one of the criteria, of course, I don't know how it's in the same protocol. I don't know by heart. I have to apologize on that. But for us, of course, we exclude patients who had committed a suicidal attempt within the 6 months that they start the study. And if they are acutely suicidal, they do not participate. So there is, of course, a difference between the suicidal ideation here and maybe to have the suicidal risk. I'm not saying that's the same.
Yeah. Well, the pilot study that I showed earlier, the the one that we did in 12 inpatients, those were all people that were admitted for major depression. Most of them were admitted for active suicidal ideation and or actually had a suicide attempt that led to their admission. A number of them had a suicide attempt that led to their admission. You know, it's small 12-person pilot, so it's not one of these things where I can make claims at all, but it's one of these things, just to kind of put a note out there, you know, the ideation went down for a long time, as I demonstrated, and then the we did not have a, you know, to our great happiness about this, in the post-discharge period, we did not have a single suicide attempt, right? So in the follow-up period between the point when they were discharged and the 6 months that we followed them, we did not have anybody attempt suicide. So I think that, I don't know, from my perspective, I think that there's likely, you know, there's like good study there to be had, you know, and I think
but I think I don't disagree with you on this. I think we should be careful. That's the only point that I wanted to make, but I do think
100%.
that it has a potential. Yes, of course.
Great. Thank you so much. Do you have a question, Samuel?
Just one. We talk about biotype, and William Lins and Cole published in Nature Medicine, you know, some description of 6 biotypes associated with particular phenotypes. So you focus on a particular biotype with the connectivity of DLPFC and subgenual single anterior. Do you feel in your practice that the same protocol better applies to a particular phenotype in your clinical practice?
Yeah.
Attention or cognitive control?
Yeah, no, that's a great question. The question is Leanne Williams' work and others looking at different, you know, Connor Liston's work, others that are looking at different biotypes of depression, and then how does that relate to what we're doing with connectivity targeting and my general clinical sense. And so just that what we're doing with targeting is agnostic to depression. So there's no depression information in there. You have a DLPFC subgenual connectivity. You're not depressed. Everybody in this room has this connection, right? So it's much more of a, you know, where is the left anterior descending coronary artery in you question, more than it's a question of, are you this type or that type? Now, to your point, and relatedly, it may be, and I mentioned this, although I didn't get like super specific about it, is there a correlation between stimulating in a subtype of people in that network and improvement or non-improvement? I won't speak to that because that's not my data to speak to. Other people are. I think that's what you're seeing with the AJP paper that Chris pointed out. I think it's just not, that's going to get borne out more, and others are seeing that subtyping people into more clinically face valid, you know, this person is like kind of a, you know, a meat and potatoes kind of depression patient or whatever. And so I think that's going to be a piece of it. And then this question of how does any of this play into what Leanne Williams is doing? My, like, I call it my non-cousin at Stanford or something. And I'm like, we share a last name. And so essentially, you know, Leanne is showing that, you know, there's whatever it is, I think 6 different, you know, biotypes of depression that are, that may be, and we got to figure that out, linked to differential responsivity to different treatments, right? And so it doesn't matter if there's a bunch of different types if they don't have a differential responsivity. But she started to do that work now, where she's showing in certain studies there's signals of differential responsivity, which would be important. And so if you've got that, then the question ends up being, are we which I think is your question, are we subsampling, which I think we are, to a population of people that are, one, maybe, and because I'm not doing this with her to prospectively say this, all her and I have talked about retrospectively looking at this, you know, are we subsampling a group? And I think we are. We're subsampling people who have face validity for depression, who meet all of these things we were talking about earlier with SAFER and stuff like that, who are a certain level of severity and treatment resistance. And to us, that is key, not just because we're trying to get one biotype or whatever, but we're trying to get a signal. Because the problem with the signal derivation is all the technical aspects of the treatment need to be right or not right or whatever, which is like what it is, you know. And then there's also the ability, even if you've got, you know, a powerful treatment in a subtype of people, you need to consistently be able to drive out that, and that's what we were talking about earlier today, that subtype of people, so you can see a signal in that population. And that, to me, is part of the difficulty, right? You know, when we're looking at Chris's data, and, you know, we were talking about earlier about his data and our data and, the, you know, the various data, it's very hard to go and have like a purely technical question, because the field doesn't have a really clear guideline on how, who and how to select the patients that are not in or out of your trial that may be a biotype issue or not, you know?
Well, very last.
A very rapid question.
Sure.
Thanks for the extraordinary outcomes that you show us. All the patients are free for benzodiazepine, and all mood stabilizer, because this is a key practical question for us.
100%.
And so, what is your strategy when you enter patients in RCT?
Yeah, and so we had this frame that and I don't know the numbers in the most recent trials, so I'd have to kind of come back and tell you what % we actually let in with this. But we did our best that we possibly could to get people as low, if not off of benzodiazepines as possible. Now, there are some people that are like very pro this idea. Some people think that it doesn't matter. I think that the signal is strong enough in the literature that as a clinical trialist that is chronically worried about things that are interacting, that it's a great question, that I want to take the risk out of the trial. And so what we try to do is to taper people as much as we can. And then we try to give them a short-acting benzo after treatment.
Which one?
You know, something like, you know, either somewhere between Xanax or Ativan, not Klonopin, not the really long-acting ones, but something that'll cover them from 5 p.m. to 8 a.m. the next morning or something, but largely be out of their system before they get their next course, if we can. Now, you know, we'll detail this in the next set of papers. It's not a perfect science. It's very hard to do, but that's been our motivation. And I would say that, I don't know, I mean, just guesstimating from what I've heard.
And for anti-epileptic, you put them off as well?
For anti-epileptics, we have, as a generality, try to get people off. We particularly get people off of what we've seen to be really MT increasing anti-epileptics. So in our hands, we've seen gabapentin weirdly drive up the MT a whole lot, whereas lamictal lamotrigine doesn't seem to do that. We're trying to pick reasonably clean people that end up being pretty clean of that to begin with. But if we're taking somebody in, then we'll try to take them off as much as possible.
Thank you so much, Nolan, and thank you, Chris. So it's time for us. We'd love to continue the discussion, but we are already running out of time. But it was a fantastic discussion between both of you guys, and again, I'm really deeply grateful to have this unique opportunity to have the discussion between two experts and pioneering folks in this field. And I won't be long for the conclusion, but I think that this webinar was illustrates very well how the clinic informs the research and vice versa. And, you know, TMS is a pretty good tool, and it's, you know, it's a diagnostic tool at the beginning, and I think we can see that, and I am really interested in, you know, looking at how much we can use, you know, biological psychiatry. We are practicing actually biological psychiatry, and this is probably the very beginning, but this discussion I think was a good illustration of where we are at in terms of for the field, and it was a great opportunity to have, you know, the US and Europe discussing about this this kind of stuff outside the conference, and again, thanks for everyone for attending this this webinar. Please become a member of the AFPB and the SBS. I think that we need you guys, and the more we are, and the faster and further the field will go. I wish you all a great afternoon, and see you soon.
Bye.
Have a great day. Thank you so much.